Good morning, ladies and gentlemen. The topic of today's lecture is cutaneous amyloidosis. I am Professor Asher Ahmed Mashood, and if you are hearing me for the first time, do join my channel to receive the earliest update on new lectures. Introduction. Amyloid means starch-like. It's a Latin word coming from amylum. This is a term introduced by Rudolf Virchow, who described the extracellular precipitates that turn brown after incubation with iodine. Even though these precipitates are protein and not carbohydrates, the term amyloid and amyloidosis are still in use. The key feature of amyloidosis is the extracellular deposition of autologous proteins as morphologically characteristic amyloid fibrils. So there are few terms which need to be highlighted in this line. That is the extracellular deposition. Number two, autologous proteins, because the proteins originate from the body. They are not foreign proteins, and they have a morphologically characteristic shape of these fibrils. Amyloidosis can be acquired or it can be hereditary. The subclassification differentiates between the localized cutaneous amyloidosis and the cutaneous amyloidosis due to systemic diseases. Amyloid can originate from various precursor proteins, but all these proteins are the autologous proteins. The pathogenic modification of these precursor proteins may be triggered by chronic inflammation, malignancies, mutation, pro-amyloidogenic peptide sequencing, and microenvironmental changes. So, although the proteins are autologous, but these proteins undergo certain changes which result in its deposition as amyloid fibrils in extracellular matrix because of various causes, which include the inflammation, malignancies, mutations in the genes, and the microenvironmental changes. Cutaneous amyloidosis and the cutaneous manifestations of systemic amyloidosis are both rare in Europe, but is far more common in Southeast Asia, China, and Southern America. The cutaneous signs are often also the key findings for the initial diagnosis of underlying systemic amyloidosis. Since systemic amyloidosis is a covert disease which cannot be diagnosed easily, and the patient usually suffer from many non-specific symptoms. So once the disease comes to the skin, then it becomes easy to make a diagnosis. Depending upon the distribution and amount, amyloid may not only lead to localized skin problem, but also cause progressive and life-threatening organ dysfunctions as we see in systemic amyloidosis. The ultrastructure and amyloidogenesis. The amyloid deposits consist of loose network of unbranched fibrils measuring 7.5 to 10 nanometer in diameter. The ultrastructural features of different amyloid precipitates is a fibrillary antiparallel beta sheet structure. So again, there are many things in this sentence. That is, the amyloid deposit consists of loose network of fibrils that are not branched. Size 7.5 to 10 nanometer. They are non-parallel, diffuse sheets of fibrillar structure, which is called as the beta sheet. And the filaments are composed of profilament and the filament aggregates to form the fibrils, the amyloid fibrils. Fibrils are found in extracellular space. So they are found in the dermis, not in the epidermis. Fibroblasts may also be involved in the process of amyloid precipitation. The second component of amyloid precipitation is the amyloid P component, which is the amount to approximately 15% of the total weight. The amyloid P component is a non-fibrillary and show a pentagonal structure. So it is mainly 85% of the amyloid comprises of the amyloid fibrils, which are the unbranched fibrils, while on 15% is amyloid P protein component, which has a pentagonal structure. So these structures are apparent on electron microscopy. The basic pathogenic principle of amyloidogenesis is an extracellular fibrillar protein aggregation, as I am repeating again and again. This may be due to different enzymatic cleavage products of precursor proteins. So I have already told you all that it is always an autologous protein. So these autologous proteins are broken down by different enzymatic cleavage processes. The two examples are firstly a truncated form of beta-2 macroglobulin, which is seen in hemodialysis-associated amyloidosis. And secondly is the gelsolin amyloidosis, which is because of distant mutation that disrupt the calcium binding of the protein gelsolin. So these are the precursor protein defects. The amyloid precursor serum amyloid SAA protein contains a pH sensitive binding site for heparin and heparin sulfate, thereby facilitating amyloid A or AA deposition in inflammatory microenvironment. So the amyloidosis that results from chronic inflammation, the main protein that is deposited in extracellular matrix is amyloid A protein, which have the sensitive binding sites for heparin and heparin sulfate. Additionally, it is known that metal ions such as copper and zinc play a crucial role in formation of A beta plaques in Alzheimer's disease, which is one of the most common amyloidopathy. Once amyloid has aggregated, serum amyloid P component stabilizes the aggregates together with other molecules such as glycose aminoglycans and the collagen fibers. So the amyloid P component in the deposition is useful as it causes aggregation of amyloid fibrils with glycose aminoglycans and the collagen fibers. The primary localized cutaneous amyloidosis is caused by mutation in OSMR and IL31RA genes. When caused by OSMR gene mutation, the condition is classified as type 1 amyloidosis, and once it is because of IL-31RA gene, it is called as type 2 amyloidosis. Mutations in either genes are likely involved in lichen as well as macular amyloidosis, which are thought to be related conditions that arise through similar disease mechanisms. The genetic basis of nodular amyloidosis is, however, unknown. Many people with primary cutaneous, localized cutaneous amyloidosis do not have mutation in either of these two genes, and in such cases, the pathogenesis or the genetic contribution seems to be unknown. In lichen and macular amyloidosis, it is thought that scratching the itchy skin causes skin cells to undergo apoptosis, releasing proteins from the cells that abnormally clump together and form amyloid. The proteins that make up the amyloids are abnormal version of the proteins which are present in the keratinocytes, that is cytokeratin. In nodular amyloidosis, amyloids are composed of abnormal version of the protein which are the immunoglobulin light chains that are released from the plasma cells. However, it is unknown how this form of primary localized cutaneous amyloidosis develops. So the lichen and macular amyloidosis is because of the proteins that originate from the cytokeratin, and the nodular amyloidosis is because of deposition of immunoglobulin light chain that are released from the plasma cells. Functional and diseases causing amyloids. It has been found that the amyloid proteins also fulfill various biological tasks, while others lead to serious diseases like Alzheimer's disease. Therefore, it is important to discriminate between the functional and disease-causing amyloids. The basic classification. In older classification, systemic amyloidosis, older classification system amyloidosis were mainly classified according to clinico-pathological features. However, in the last decade, with improvement in molecular biology, the proteins involved in different types of amyloidosis has been characterized. So there is a tendency to use biochemical features of amyloidosis in classification. However, several different types of clinical amyloidosis are characterized by different kinds of amyloid deposition. Hence, it is better to use both the clinical features and the biochemical features in the classification of amyloidosis. So the cutaneous amyloidosis is classified as the primary localized cutaneous amyloidosis, abbreviated as PLCA, the secondary localized cutaneous amyloidosis, abbreviated as SLCA, systemic amyloidosis with cutaneous involvement, and secondary cutaneous amyloidosis that originate from other systemic diseases. The clinical presentation. The localized cutaneous amyloidosis often show yellowish or brownish macules, papules, or plaques of various configurations. Whereas the cutaneous amyloidosis due to systemic diseases often initially presents as fatigue, ecchymosis, and non-healing ulcers. These differences in clinical presentation are due to the level or depth of amyloid deposition. Since in primary localized cutaneous amyloidosis, the deposition occur in papillary dermis, whereas in systemic amyloidosis with cutaneous involvement, the deposition occur deeper in reticular dermis, in subcutaneous, along the dermal appendages and blood vessels. It is the amyloid precipitation in blood vessels that make the vessels fragile, causing intracutaneous micro and macro hemorrhages due to small trauma and even by coughing or sneezing. For cutaneous amyloidosis, pruritus is very typical and a very common symptom, and also a reason of amyloidosis. Investigations for cutaneous amyloidosis. The first and foremost is biopsy and histology. The standard staining is HNE, toluidine blue, crystal violet, methyl violet, or alkaline fuscin. Amyloid staining for polarized macroscopy include Congo red and thioflavin T. Immunohistochemistry may also be used. Pan-cytokeratin antibody or for AK amyloid, the cutaneous amyloidosis, and immunoglobulin light chain antibodies, kappa or lambda chain, is used for the nodular cutaneous amyloidosis. Electron microscopy I will describe later. How to take the sample. Skin samples are taken in primary cutaneous localized amyloidosis, while abdominal fat and rectal biopsies are taken for nodular primary localized cutaneous amyloidosis and in cutaneous findings of systemic amyloidosis. Baseline investigations when you suspect a patient suffering from systemic amyloidosis, we order serum creatinine, GFR, the protein urea, full blood count, ECG, coagulation profile, NT-proBNP, and troponin TI when cardiac amyloidosis is suspected. Amyloid subtype dependent investigation. In suspected AL amyloidosis, serum and urine protein electrophoresis, immune fixation, free light chains in serum, detection of free light chains in serum, bone marrow biopsy and skeletal imaging is done. In suspected cardiac amyloidosis, ECG, cardiac MRI, 99M TCD-PD or pro-phosphate scan is also performed. In suspected hereditary amyloidosis, gene sequencing is done. Whole body amyloid load is determined by ISAP 123 iodine labeled amyloid P component. This is again a radioimmunodiagnosis. In patients with nodular primary localized cutaneous amyloidosis, it is appropriate to assess for progression to systemic amyloidosis on regular basis. This assessment should include full history, physical examination along with the ECG, complete blood count, serum creatinine level, serum liver-associated enzyme level, and serum protein electrophoresis and urine protein electrophoresis. The chances of systemic progression in primary localized cutaneous amyloidosis is 0. So these investigations are not required in primary localized cutaneous amyloidosis. Any indication of systemic disease requires immediate attention as it is a progressive condition. Histology. In papillary, lichenoid, or macular amyloidosis, it is found that papillodermis directly below the basal epidermal layer is the site of amyloid deposition. Epidermis, however, show hyperkeratosis and acanthosis. Other histological features are some amount of eosinophilia, PS positivity in the material, staining with Congo red or thioflavin T as metachromasia after staining, as well as metachromasia after staining with crystal violet or methyl violet. Metachromasia is the change in skin color, change in color from the stain. If you give a violet stain and it becomes red or blue, then it is a change in color. Using Congo red, amyloid exhibit a characteristic apple green birefringence under polarized light. This is a phenomena called as dichromism. This phenomena is called as the dichroism. Blood vessels remain unaffected in primary localized cutaneous amyloidosis like macular and lichen amyloidosis. In contrast, blood vessels may be affected in nodular or tumefactive primary localized cutaneous amyloidosis. This is how amyloid would look like on histopathology if we take a biopsy of macular amyloidosis. So, pink diffuse faceted appearance in the papillodermis. Along with that, there is a little bit of pigmentary incontinence as well. In lichen amyloidosis, there is hyperkeratosis and acanthosis, along with amyloid deposition and pigmentary incontinence. This is a Congo red staining of amyloid deposits. On polarized microscopy, this will give an apple green birefringence, as seen in the picture. The nodular or tumefactive cutaneous amyloidosis, this amorphous amyloid material is seen occupying the reticular dermis as well, and on toluidine blue staining, they become more obvious or take up the toluidine blue stain. As mentioned before, in recent years, the abdominal fat pad and rectal mucosa fine needle aspiration biopsy has become an important tool for diagnosing systemic amyloidosis. This is because of easy access, practicality, and high sensitivity of these investigations. Immunohistochemistry. For immunohistochemistry, antibodies are available for the subclassification of amyloid precipitates that are directed against cytokeratin, which is amyloid K proteins, or amyloid L proteins, which are immunoglobulin light chain derived seen in nodular amyloidosis. The cytokeratin profile of primary and secondary localized cutaneous amyloidosis has shown positivity for cytokeratin 5. The cytokeratin 5 is predominant cytokeratin found in the basal keratinocytes. And this is a predominant cytokeratin protein which is found in amyloid as well. In descending frequency, other cytokeratins which are found include cytokeratin 1, 14, and 10 in primary, and cytokeratin 1, 10, and 14 in secondary cutaneous amyloidosis. Antibodies against cytokeratin 5 is used to diagnose amyloidosis in H and E sections. Electron microscopy. This is the electron microscopy image of amyloid deposits showing the amyloid precipitate as fibrillary, anti-parallel. You can see that these fibrils are not parallel to each other, showing aggregates of amyloid fibrils which have a size of 7.5 to 10 nanometer each in diameter. The classification of localized cutaneous amyloidosis. It is sporadic, localized cutaneous amyloidosis, or hereditary, localized cutaneous amyloidosis. In sporadic, it includes papillary or lichen amyloidosis, macular amyloidosis, nodular amyloidosis, and secondary localized cutaneous amyloidosis. While hereditary, it includes familial, primary localized cutaneous amyloidosis. Localized cutaneous amyloidosis, which is the type that concerns us mostly. Definition. In localized cutaneous amyloidosis, amyloid precipitates are limited to the skin and mostly to the papillodermis. It can be hereditary and non-hereditary. It can be primary and secondary, which is described as sub-entities of non-hereditary localized cutaneous amyloidosis. Introduction and general description. The group of localized cutaneous amyloidosis comprises of mainly the papillary or lichen amyloidosis and macular amyloidosis. And the third is the tumefactive or nodular type. The macular amyloidosis and papillary amyloidosis both contribute to 35% of the total amyloidosis, while the mixed type, in which both the macular and papillary exist, contribute to another 15% of the primary localized cutaneous amyloidosis. The nodular or tumefied type of primary localized cutaneous amyloidosis is extremely rare and contribute to almost 1.5% of total cutaneous amyloidosis. As far as the gender is concerned, women seems to be more frequently affected than men. The ratio is 2 to 3 ratio 1. In contrast to lichenoid form, the macular primary cutaneous amyloidosis is much more common in women than in men. It is reported that countries near to the equator, the prevalence of primary localized cutaneous amyloidosis is high. And the mixed maculopapular PLCA is 15% more frequent in Asian, than the macular type. The most common entity of non-hereditary PLCA is papillary or lichen amyloidosis. So the papillary lichen amyloidosis is more common than macular amyloidosis. The overwhelming majority of localized cutaneous amyloidosis occur sporadically with no known predisposing factor. Associated diseases. The associations between the papillary and macular primary cutaneous amyloidosis and multiple endocrine neoplasms 2A have been reported. A case report described a possible association of macular amyloidosis with primary biliary cirrhosis. Nodular form of primary localized cutaneous amyloidosis is often found in diabetes, Sjogren syndrome, and Crest syndrome. Phenomena of Koebner phenomena is also seen in lichen amyloidosis. Often, secondary amyloid deposition occur in association with skin tumors like basal cell carcinoma, actinic keratosis, squamous cell carcinoma, and certain appendigeal skin tumors, and benign lesions like seborrheic warts, solar elastosis, collagenoses, for example, lupus erythematosus and after PUVA therapy. So secondary amyloid deposition is seen secondary to certain skin malignancies, certain benign skin tumors, the solar elastosis, collagenoses, and after PUVA therapy. Pathophysiology. A common accepted theory for papular and macular type of primary localized cutaneous amyloidosis is that due to scratching or friction, there is basal cell apoptosis. They fall down in the dermis, release cytokeratin, which is then covered by autoantibodies, phagocytosed by the macrophages, and enzymatically degraded to form amyloid K protein. As mentioned before, cytokeratin 5 and rarely cytokeratin 1, 10, and 14 is the major constituent of amyloid in both papular and lichen form of the macular cutaneous amyloidosis. Papular and macular form. In macular primary localized cutaneous amyloidosis, friction plays a key role as it is the mechanical stimulus that induce apoptosis of basal keratinocytes. In this context, pruritus, which provokes scratching and provokes friction, is thought to induce amyloid K deposition. So this starts from a non-specific pruritic skin condition. And this deposition in turn leads to more pruritus, and hence this becomes self-sustainable as a cyclic process. More scratching, more amyloid deposition, which causes more scratching and more deposition. This is known as the friction or brush amyloidosis. Friction amyloidosis is sometimes also classified as a form of secondary cutaneous amyloidosis. Although the other causes of secondary cutaneous amyloidosis are benign or malignant skin tumors. The rare form of nodular PLCA is characterized by amyloid light chain deposition. Plasma cells infiltrating the skin produce the monoclonal immunoglobulin light chain of kappa and lambda type as amyloid precursors. There are two major factors that differentiate nodular amyloidosis from macular and lichen amyloidosis. Firstly, the nodular amyloidosis comprises of immunoglobulin light chains derived from plasma cells, whereas papular or macular amyloidosis is derived from cytokeratin. Secondly, the amyloid in nodular amyloidosis involve the whole dermis and even subcutaneous fat, blood vessels, and appendages, while the amyloid deposition in papular and macular amyloidosis is only in the papillary dermis. Linkage of familial PLCA to locus on IQ23 and mutation in interleukin 31 receptor A gene is discovered. So multiple mutation in OSMR beta gene have also been described as already mentioned. The altered gene expression pattern probably accounts from lichenification found in patients with familial PLCA. The clinical features. The characteristic clinical symptoms of cutaneous amyloid precipitate is intense pruritus. In papular type, firm papules with pink to brown lichenoid glossiness are found on leg and on the trunk. Whereas in macular amyloidosis, well or vaguely demarcated, hyperpigmented, yellow to brown. Macules are present in interscapular areas. These macules are along the skin creases and they are not diffuse. So you can see in this picture, this is a picture of macular amyloidosis, and this is a picture of lichen amyloidosis in ankle of a patient. Nodular primary localized cutaneous amyloidosis, which is a rare form, present as solitary or multiple, asymptomatic, brown to red, firm plaques or nodules, typically on nose, leg, typically the feet, genitals, and trunk. So this is the tumefactive or the nodular primary localized cutaneous amyloidosis showing the plaque-like structures on the nose, on the feet, and even on the scalp. The clinical presentation of hereditary type of PLCA, it's autosomal dominant and does not significantly differ from the non-hereditary papular form of primary localized cutaneous amyloidosis. Often lignification of skin and tiny dome-shaped papules predominate on the ventral body areas. So this is familial primary localized cutaneous amyloidosis showing papular lignification with tiny dome-shaped papules. In addition to these major types, clinical variants include the mixed or biphasic primary localized cutaneous amyloidosis, which is a variant of lichenoid and macular amyloidosis, in which both the features are present. Poikilodermatous form of PLCA exists, in which lichenoid and macular lesions are seen in combination with blisters and poikilodermatous skin lesions. Then there is a condition called as amyloidosis cutis dyschromica, which is mottled hyper and hypopigmented macules with amyloid deposits derived from cytokeratin. Then bullous form of amyloidosis also exists in both primary localized and systemic amyloidosis with cutaneous feature. Differential diagnosis. The papular or lichen amyloidosis must be differentiated from lichen simplex chronicus and hypertrophic lichen planus. The macular type of cutaneous amyloidosis should be differentiated from atopic eczema, the chronic atopic eczema, the post-inflammatory hyperpigmentation, fixed drug eruptions, atrophoderma of Paciniae and Perineae, anetodermas, and morphea, because morphea also have brownish pigmentation. The nodular or tumefactive form of primary localized cutaneous amyloidosis must be differentiated from nevus lipomatosis, cutaneous lymphomas, squamous cell carcinoma, warts, adnexal tumors, keloid, and hypertrophic scars. Complication and disease course. While papular and macular primary localized cutaneous amyloidosis is mainly an aesthetic problem, sometimes it's quite problematic because of the pruritus and debilitating symptoms. There are chances that the nodular or tumefactive form of primary localized cutaneous amyloidosis turns into systemic amyloidosis, and the rate of progression is between 5 to 50%. Given the data available and understanding, the nodular PLCA appear to be localized clonal plasmacytoma, and likely that the true rate of progression is quite low, not as high as 50%. Then something about cutaneous amyloidosis due to systemic diseases. So the cutaneous amyloidosis due to systemic diseases comprises of three groups. the non-hereditary systemic amyloidosis with cutaneous involvement, the hereditary systemic amyloidosis with cutaneous involvement, and hereditary systemic amyloidosis with secondary cutaneous amyloidosis. There are different diseases in each group. For example, in non-hereditary systemic amyloidosis with cutaneous involvement is due to primary and myeloma or plasmacytoma associated amyloidosis. So the main pathology is a primary melanoma or plasmacytoma, as well as amyloidosis due to Waldenstrom macroglobulinemia, in which both the light and heavy chains are seen. It can be because of tumors and hemodialysis. In hereditary systemic amyloidosis with cutaneous feature, the conditions that lead to systemic amyloidosis are the hereditary transthyretin amyloidosis, which results in familial amyloid polyneuropathy. Then second condition is hereditary apolipoprotein A1 amyloidosis. Third condition is hereditary cystatin C amyloidosis. And fourth condition is hereditary Gelsolin amyloidosis, also known as the Meritoja syndrome. Then the third type of systemic amyloidosis is the hereditary systemic disease with secondary cutaneous amyloid deposition. This is seen in two conditions, the Muckle-Wells syndrome and the tumor necrotic factor receptor 1 associated periodic fever syndrome known as the TRAPS. Introduction and general description. Systemic amyloidosis are often characterized by amyloid deposition in mesenchymal structures of internal organs, such as heart, muscle, liver, kidney, which lead to progressive loss of function and eventual death. The epidemiology. The systemic amyloidosis show cutaneous involvement in 50% of the patients and allow the physicians to diagnose the underlying systemic disease at an early stage. So the skin findings of a systemic disease is always considered to be a bonus or plus point for the diagnosis of this hidden or covert disease. Pathophysiology. Most non-hereditary primary systemic amyloidosis are caused by the monoclonal plasma cell proliferation. The underlying diseases have been mentioned before: melanoma, plasmacytoma, Waldenstrom macroglobulinemia, etc. The common feature of these diseases is production of monoclonal immunoglobulins. Mostly these are immunoglobulin light chain of both kappa and lambda type. And the deposition is AL or amyloid light chain deposition. The ratio of kappa and lambda chain is 1:2. So more of the lambda chain. However, in patients with Waldenstrom macroglobulinemia, both amyloid light and amyloid heavy chains are seen. Despite the clinical variability of AL type amyloidosis, petechiae and purpura of face and intertriginous areas are considered as the cutaneous feature of systemic amyloidosis of any type. You can see in the picture the periorbital bleeding following cuffing and the plasmacytoma associated systemic amyloidosis with purpura and ecchymosis in the inguinal region. The suspected reasons of hemorrhages in systemic amyloidosis is, beside the deposition of amyloid in the vessel wall leading to fragility, it is decrease in factor 10, which causes difficulty in blood clotting. Amyloid precipitation is also seen in oral cavity as papules on the lips as well as macroglossia. You can see the papules on the lip and macroglossia, again, the two features of systemic amyloidosis. In secondary systemic amyloidosis, a specific underlying disease leads to deposition of amyloid in different sites, and most common amyloid here is AA, or acute phase protein amyloid. So the secondary systemic amyloidosis is because of chronic inflammation, both infectious and non-infectious, neoplastic diseases, sporadic gene defects, all enhance the serum amyloid A protein deposition. Skin signs are same as that of the other type of systemic amyloidosis, that is purpura, plaques, and nodules. Clinically normal skin may show amyloid A deposition. The disease shows tendency to regress when the underlying disease is treated. Another variant of secondary systemic amyloidosis with cutaneous involvement is seen in hemodialysis patients with beta-2 microglobulin beta sheet-like structure as amyloid precursor. As the hemodialysis is stopped, this kind of amyloidosis is also cured. Muckle-Wells syndrome is one of the cryoprin-associated periodic fever syndrome caused by NLP3 mutation. As mentioned before, the clinical features of systemic amyloidosis is characterized mainly by petechiae, hemorrhages, ecchymosis, and pruritus. Bleeding is often seen in periorbital or intertriginous area. Then amyloid purpura also occur above the nipple line, mostly on head and neck and eyelids. As a clinical variant of light chain amyloidosis, the bullous cutaneous manifestations, which may be hemorrhagic, or bullous manifestations or also occur in the oral mucosa. So you can see a hemorrhagic bulla on the hand in patient of systemic amyloidosis. Another feature of systemic amyloidosis is confluent white to yellow, waxy, partially hemorrhagic, papules or nodules predominantly occur on the face, eyelids, and scalp. And in severe cases, the lesions may lead to ulceration and scarring alopecia. Another feature is if dermis is extensively infiltrated by the amyloid deposition, scleroderma-like changes occur on hands and fingers, which is known as the scleroderma amyloidosum gotral. Scleroderma amyloidosum gotral. Also, the blisters and nail dystrophy is reported manifestation of myeloma-associated amyloidosis. Among the hereditary subtypes, the most common is familial amyloid polyneuropathy due to deposition of altered transthyretin, a protein from prealbumin fraction. Other form of hereditary systemic amyloidosis include associated with cardiomyopathy. Here, apolipoprotein A1 amyloidosis is deposited. Multiple cerebral hemorrhages in which cystatin C amyloidosis is deposited. And carpal tunnel syndrome, which is also a feature of systemic amyloidosis. Massive, deforming cutis lexa, extensive petechian hemorrhage, hypotrichosis, or alopecia is seen in Gelsolin amyloidosis, also known as Mary-Toja syndrome, which is a form of hereditary systemic amyloidosis. Combination of prolonged fever episodes, abdominal pain, myalgia, migrating cutaneous erythemas, is characteristic of rare TRAPS syndrome. In Muckle-Wells syndrome, there is cutaneous amyloid deposition with urticaria-like lesions and development of sensorineural hearing loss. So these all are various types of systemic amyloidosis. The last part of the talk is the management of cutaneous amyloidosis. In the treatment of different forms of cutaneous amyloidosis, always is a challenge. Multidisciplinary approach should be undertaken in case of systemic amyloidosis, as treatment of underlying condition will treat the cutaneous features. And since the disease is highly progressive and fatal, they should be managed promptly. In all types of cutaneous amyloidosis, antipruritic treatment should be the one and the foremost component. So topical treatment should be tried in case of primary localized cutaneous treatments. These options may be followed with laser and surgical approach. In contrast, the primary localized cutaneous amyloidosis with widespread vision require use of photochemotherapy, systemic drug treatment like DMSO, acitretin, and cyclophosphamide. So we are discussing these things. So the topical treatment, the first line is the topical administration of potent topical corticosteroids with or without occlusion, or intralesional corticosteroid injection. DMSO up to 50% may be used as a topical agent to prevent pruritus. DMSO also helps in penetration of corticosteroids into the dermis. The second line treatment include phototherapy with narrowband UVB or photochemotherapy with PUVA. The third line treatment is the surgical treatment. It can be helpful in nodular form of PLCA, which includes shave or complete excision or split skin thickness grafting. Non-invasive surgical treatment include dermabrasion, curettage, and cautery. Among the laser therapy, pulse dye laser and CO2 fractional laser resurfacing are successfully employed in the treatment. Systemic treatment. The most important systemic agent which is used in the treatment of cutaneous amyloidosis is the oral retinoid, such as acitretin. This requires administration for over 6 months in a dose of 0.5 milligram per kilogram body weight. Not only relieve the pruritus, but also improve the papules and macules and hyperpigmentation after 4 months of therapy. Oral DMSO can be tried in systemic amyloidosis with cutaneous involvement. In patients which are not responsive to acitretin, cyclophosphamide 50 milligram daily can be given for 6 months with good results. In systemic amyloidosis, it is crucial to treat the underlying condition, that is multiple myeloma, plasmacytoma, and renal insufficiencies. The treatment for each of these conditions is beyond the scope of this lecture. Further treatment with SIR, NAs, or anti-amyloid antibodies are under development. Since interleukin-31 is a key player in pruritus, development of antibodies against interleukin-31, known as the nemolizumab, has shown a great promise. The primary systemic amyloidosis or diseases with secondary cutaneous amyloid precipitation should always be treated by a multidisciplinary team. Immunosuppression is core component in treatment of systemic amyloidosis secondary to inflammation. In case of amyloid A deposition, which is due to inflammation resulting from familial Mediterranean fever, colchicine is used as an important treatment tool. In addition, anakinra, which is the interleukin-1 receptor antagonist, may be used alone or in combination with colchicine in such cases. The TRAPS-associated amyloidosis is treated by tumor necrotic factor blockade and interleukin-1 antagonists like anakinra. Muckle-Wells syndrome is treated by canakinumab or rilonacept and anakinra. Administration of intravenous immunoglobulins and plasma exchange is also successful. Increased number of patients with A beta 2 amyloidosis, which results from prolonged hemodialysis, enable the long-term patient with the chronic renal failure. Improvement in renal functions will result, and stopping of the hemodialysis results in improvement of this kind of amyloidosis. So this brings me to end of this talk. Thank you very much for your patience and listening. Hope to see you next time with another edition of my lectures. Goodbye and have a very good day.